Okay. Good morning, everyone. So the first lecture out of 4 that we have right now is pleural diseases. We'll try to cover as many things as possible. But just before we start, I wanted to share some of my experience doing the multiple choice exam just a few years ago. I found that the question stems were very long. It takes a while to read through the whole thing. And sometimes by the end of the question, I already forgot what they were trying to ask and what was stated before. After a while, I started reading the actual question first, the last line right before they make you make the choices. And then I go back and then read the scenario from beginning to end. And then I will highlight keywords as I go. And another thing was sometimes I look at the choices and some of them seem, maybe they're 2 best answers, but they're asking for 1 best. In those situations, I find it helpful to try to think what's the examiner trying to test, or what's the examiner trying to trick you with. And there are times that you would think back in your training and, oh, so-and-so did this as opposed to that. But sometimes what we do in clinical setting may not be the guideline that they're looking for to test you on. So don't let anecdotal experiences bias you. And then the next thing is it's a strategy. I found that it was a marathon. And when you first start, the first 1 or 2 blocks were fine. But as you get closer to lunch, you start losing energy. And then once you get to the afternoon, I ran out of steam. So knowing that it's going to be a marathon, there's some strategies that you can use, and I'm sure you can come up with ways that fit your exam writing style the best. So for me, I avoided eating 1 large meal at once. I brought lots of snacks so that when I had breaks or something, I would come out and have a little bit. And sometimes eating a little bit of snack will wake you up a little bit if you feel that you're falling asleep. Maintain your hydration, use the breaks. And then for the lunch breaks, people have different philosophies. Some people will rest and not think about it at all. Other people will try to look up things that they missed in the morning session, and they wanted to look it up so that they have a peace of mind in case that they run into the same similar type of questions in the afternoon. And as I said, expect that you will run out of steam near the end, so plan ahead for it and plan your coping strategies. And the studying strategy is definitely different for written versus oral exams. I know that for the written exam, you need to know everything and to the level of detail that you may not think it's necessary. So you do need to know all the tricky and obscure details. And especially for guidelines, you want to read all the fine prints. And what are the fine prints? For example, everyone knows the staging system, but do you really know the lateral border of level 4R, for example, for lung cancer? Well, as most people think it's in the midline of the trachea, but actually the division point between 4 and 4L is actually the left lateral border of the trachea. So there are a lot of these little tricky fine prints in the guidelines, whether it's in the cancer staging guideline versus your cardiac guidelines. And I also made a list of things to look at the day before the exam or the evening before the exam. These are the things that you can store in your working memory for limited amount of time. So if you look at them a few days earlier, you may not remember them the day of the exam. So I have my own memory aids. Mine consists of, looking at all the AJCC staging. There are always questions on staging. They expect you to know for sure the lung cancer staging, esophageal cancer staging. More and more, I find that they ask about genetic mutations, especially those mutations that they can target with targeted therapies. And then some of the neoadjuvant, adjuvant trials for lung cancer and esophageal cancer. The NSLT findings, sometimes they'll ask you the fine prints on that. Fleischner's guideline, they would literally give you a nodule, describe solid, subsolid, 8 millimeters. How many months later do you want to repeat your scan? And some of the ICU key formula that they may ask you to calculate. There's always questions on chest wall tumor. They'll ask some obscure rare chest wall tumor and sometimes thoracic inlet anatomy. So these were the things that I have ready to read the night before the exam. So here we'll begin our lecture on the pleural diseases. We're going to go through complicated cases because they're not going to ask you simple things. So simple things you can observe, simple effusions, you can drain it, put a catheter, put a chest tube. These ones are for sure not on the exam. On the exam, they're going to ask you something a little trickier. So first, let's talk about complicated pleural effusions and trapped lung. We're going to go through the benign and malignant etiology. So history of empyema, it's been there for a long time, but it wasn't until early 20th century that there was advanced technological advances allowing chest tubes and modern thoracic surgery. The evolution of parapneumonic effusion, it goes through 3 stages. Exudative stage, this is where the effusion is simple, free-flowing, and the cultures are usually sterile. And then the second stage, this is where the complicated pleural effusion starts. So there are going to be loculations, septations, there's going to be bacteria in the culture, and the fibrin deposition starts. And then the third stage is fibrotic stage. This is when your body starts to put in the fibroblastic ingrowth, collagen deposition. So this is where you start getting the thickened pleural peel and trapped lung. And this is important because the management differs between when you have trapped lung versus you don't. And so that's a major, I guess, a distinction point, how you manage these people. So for example, after I drain a pleural effusion, if I get a chest x-ray, like on the left, that's now the trapped lung. If I get a CT scan on the right, that's trapped lung. So the options for treatment are very different. The trapped lung will never fully expand to fill the empty pleural space. The empty space will continue to accumulate fluid. And when it's in the context of an infected space, such as empyema, once you have trapped lung, the answer should be complete decortication. And pleural catheter is contraindicated because you're putting a foreign body in an infected field. And this is development of pleural effusion in the pneumonia. And this is stage 2 and stage 3 parapneumonic effusion. In stage 2, as you can see, once you drain the empyema, the lung will completely fill the space, obliterate the space. Whereas in stage 3, even if you drain it, you still have an empty space where bacteria and pleural effusion can reaccumulate. The initial management is the same. You want to take cultures, do your imaging, drain it, sample it, send it for culture, and then start appropriate antibiotics and change it based on your sensitivities. You also want to treat the underlying cause. If the patient's having aspiration pneumonia, you want to put them to NPO, get the SLP consults. Or if there's other sources of infection elsewhere in the body, you want to treat that to avoid further seeding. And then you want to repeat the X-ray and CT after you drain it to see how completely you've drained it and whether the lung is expanded completely. If the lung can, is a little bit trapped, but you don't think that it's a thick fibrotic pleural peel, you can try fibrolytic therapy. So this can break up thin pleural rinds, but it's not going to be able to break up very thick pleural rinds. And surgical decortication will be able to, is amenable for both the thin and thick pleural rinds. So this is a trial, double blind randomized trial, MIS2 trial that showed that the 10 milligram of TPA, 5 milligram of Dornase, BID 3 days is better than placebo and better than single agent, either one alone. So by combining both agents, reduce the frequency of surgical referral and length of hospital stay compared to placebo. But if you have a thick pleural rind, you should consider surgical decortication. And you can do a VATS or through thoracotomy. And these are the steps, which it would be good to come up with, a few steps like that for every operation for the oral exam, but this is less relevant for the written exam. So with the decortication, you want to create space between the parietal and visceral pleura. You want to drain all the pockets of fluid, break apart the loculations, lyse all the adhesions that have formed, and also lyse the thick pleural peel. Then you irrigate, wash out, and leave some large wall chest tubes. So that was the benign etiology for complicated pleural effusion. Next, we're going to do the malignant pleural effusion. The exact mechanism and pathophysiology is still unclear, but currently we think that the pleural fluid is produced from the visceral pleura, and usually the pleural effusion is drained by lymphatic stomata on the diaphragmatic surface of the parietal pleura. And various cancers, whether it's lung cancer or metastases from other places, they obstruct this fluid absorption mechanism. And also, because of many other factors, there's increased hydrostatic pressure and proliferative stimulants. And for long-standing malignant effusions, you can have lung entrapment from thick pleural rind, and in this case, it's mostly built from fibrin and tumor, resulting in an oncothorax. So this is a malignant pleural effusion that has gradually over time become trapped. And once you have a complicated malignant pleural effusion where you drain the fluid, but the lung doesn't completely expand, there are a couple of options. One is pleurectomy and decortication, with or without intraoperative hyperthermic chemoperfusion. But this is mostly reserved for treatment of mesothelioma. It's rarely used in treating other malignant pleural effusions. There's also intrapleural photodynamic therapy and other things, but again, that's for mesothelioma. Once you have trapped lung in a setting of malignant pleural effusion, then the third option is Pleurex. So for small effusions, as usual, it can be watched. Sometimes as you go through treatment, it can respond to treatment and can resolve on its own. But large and symptomatic effusions have to be drained for symptomatic relief and for earlier return to systemic therapy. Once you do the thoracentesis, always send for cultures and cytology. You want to establish tissue diagnosis if you don't have one yet, and treat the underlying tumor. After thoracentesis, in some people, it completely expands. If it completely expands, then you have more options. You can watch, do serial thoracentesis, do Pleurex, or you can, these patients are amenable to some form of pleurodesis. But if after thoracentesis, the X-ray looks like the one on the right-hand side, that means the fluid will reaccumulate, and you need to think of something else. So here are the questions to ask. So if a question says large pleural effusion, you drain it, okay, and then what do you do next? So a couple of things you need to look into the stem of the question is, did it recur? How quickly does it recur? Is there a trapped lung on imaging that they're showing you? Does the patient respond to cancer therapy? So certain cancers respond very well to systemic therapy. So even if it's a large effusion, you can wait for the patient to have chemo and then decide. So lymphoma, breast, ovarian, small cell, these things all respond well to systemic therapy. And you also want to ask what's the cancer prognosis, functional status, and also you want to know if there's any active infection. If the patient has a concurrent aspiration pneumonia, then you don't want to put a Pleurex in. You may want to just do the serial thoracentesis or regular chest tube until the pneumonia resolves, and then put in the Pleurex at a later date. So here are some of the comparison advantages and disadvantages. Serial centesis, if the rate of reaccumulation is slow, or you can use it when patients have active infection and you don't want to leave any foreign body inside the patient, or patient preference. For the indwelling pleural catheter, you want to leave it in if reaccumulation is fast so that you don't interrupt their chemo or radiation therapy. But you absolutely have to rule out active infection in the lungs or any